Good evening friends, welcome to my channel Critical Care Basics. In this channel, in the last lecture we were talking about how to treat a patient of stroke in the ICU. So in the last lecture we talked about the different types of stroke and the pathophysiology. In this part 2 of stroke, we will discuss about what happens when the patient is brought to the door of the emergency department in the hospital. So let's begin stroke part 2. We have seen this slide in our last lecture. These are the 8 Ds of stroke. So we have covered this detection, that means rapid recognition, the BFAST scale. We have discussed about the EMS and the ambulance and the transport. So now this patient has landed into the emergency department. So imagine somebody developed a weakness in the right arm and he has developed a slurring of speech and the facial angle droop and the deviation of facial face, and within last say 45 minutes and is being wheeled into the emergency department. So what is triage after all? Triage is a preliminary assessment of patients or casualties in order to determine the urgency of treatment. So because we have to immediately think of recanalization in stroke, stroke is emergency. Because every minute 19 million neurons are dying if it is an ischemic stroke. So every minute delay means a lot of brain tissue is dying. So this comes in the most urgent treatment care needed. So triage sign red. So as soon as you see a stroke patient, the assessment begins like any other primary survey. So you begin with airway, breathing and circulation. So observe the patient, whether the patient has dysphagia. If the patient has dysphagia, let there be a validated assessment form, because these are the patients who would probably require intubation. Do a quick cardiovascular survey, see for irregular heart rate, see for AF, see for any structural heart disease, see for arrhythmias, any carotid bruise and or heart murmurs. Also do a quick respiratory examination, see for the SpO2 and see for whether the patient has pulmonary edema or the patient has aspiration pneumonia. Now these are the category of stroke patient who are going to require intubation, early intubation. Patient with decreased GCS. So patient who's deeply unconscious, probably less than GCS 9 or 8, will require intubation for airway protection. And those patients who are otherwise conscious but have signs of bulbar dysfunction like dysphagia, dysphonia or stridor or change in voice. So these are the patients who probably have a brainstem infarct and they will require airway protection in form of intubation for airway protection. If the patient have raised ICP either due to hemorrhage or vertebrobasilar insufficiency or bihemispheric ischemia, so then these patients can present with vomiting, decreased respiratory drive and or muscular airway obstruction. So these are the candidates for intubation. Lastly, if the patient is unconscious and hypoventilating, so hypoventilation can cause CO2 retention. CO2 retention causes cerebral vasodilatation and that in turn causes increased intracranial pressure. So all those patients who have respiratory acidosis and hypercarbic and who should be immediately intubated and ventilated. Now before we go into the clinical features of stroke, let's briefly discuss stroke mimics. Stroke mimics are those conditions which look like stroke but they are not stroke. The most common, as we have already discussed in last lecture, is hypoglycemia. So do not forget to check blood glucose in every patient with suspected stroke. It can present variety of neurological deficit like aphasia and hemiplegia. Second is intracranial space occupying lesion. It could be a tumor or abscess, intracranial bleeds. So they usually have localizing signs. Some patients will also have seizures. Seizures themselves or postictal state can present like a stroke. So if the patient, for example, has a tongue bite, so probably patient had a seizure, and Tort's paresis is a focal deficit following a partial motor seizure or a generalized seizure. Hemiplegic migraine can present as stroke mimic. Stroke may look like a stroke. Different encephalopathies and metabolic disorders like hyperglycemia, especially hyperglycemic non-ketotic coma, hypertensive encephalopathy, or hyponatremia, uremic encephalopathy, hepatic encephalopathy, even sepsis, infective encephalopathy may look like a stroke. Drug toxicities include lithium, carbamazepine and phenytoin toxicities, and some people, even functional disorders can mimic stroke. For example, in panic attack, acute weakness or sensory disturbance following a trigger may mimic a stroke, but inconsistent clinical examination so gives way to the diagnosis of a functional disorder. Now, what do we do in a patient of suspected stroke? As soon as you see the patient, you decide whether this is a stroke first of all. Second, determine the time window. When was the patient last seen normal without the neurological deficit? Obtain a clue to the mechanism of stroke, whether it is looking like a thrombotic stroke, embolic stroke, or whether it is looking like hemorrhage, and avoid potential complications of therapy. So do not start a therapy which can worsen the patient. For example, patient has come with a BP of 160/100 in a stroke, and you try to reduce the blood pressure. That is potentially harmful. So do not do anything that could harm the patient. The focus should be on when did the first symptoms occur, when was the stroke onset, because the thrombolytic therapy can be given for 3 hours or 4.5 hours after the initial onset of stroke. How the symptoms evolved, whether it was a stuttering course, whether it was maximal deficit on onset, whether the patient has any vascular risk factors like diabetes, hypertension, or dyslipidemia, obesity, smoking, tobacco, what medication the patient is on, whether the patient is taking some antiplatelet drugs or anticoagulants, whether the patient is suffering from diabetes, hypertension, we have covered this. Are there any contraindications? While the patient is being screened for the stroke and being prepared for CT scan, just go through the history, examination, and see for any contraindications for thrombolysis or contraindications for endovascular treatment or contraindications for anticoagulation, whatever is required. If it is unwitnessed stroke or wake up stroke, what if the patient gets up and finds that he has a weakness on the one side of the body? When the exact time of stroke onset is not known, it is defined as the last time the patient was seen normal. For patient whose stroke symptoms are first noted upon awakening from the sleep, the time they went to bed or the last time they were seen to be normal by a friend or a relative is taken as the time of stroke onset. Such patients usually come late, so such patients are usually not eligible for intravascular thrombolysis unless the last time known to be normal is less than 4.5 hours. However, sometimes imaging based criteria, like you do an urgent MRI and you see a infarct which is seen in the diffusion but not seen in the flare image, which is called a diffusion flare mismatch. Such select patient can be considered for thrombolysis or mechanical thrombectomy. See for associated symptoms like fever. If there is fever, think about embolic stroke, infective endocarditis. Even infections can raise the acute phase blood reactants and they could predispose the patient to thrombosis. Headache usually means a hemorrhagic stroke, but some patients have headache in the prodromal phase of thrombotic stroke also. Vomiting is usually again indicative of intracerebral hemorrhage, of subarachnoid hemorrhage, although posterior circulation stroke can have vomiting. Seizures are rare in patients with thrombosis. So if the patient presents with seizures, it could be lobar intracerebral hemorrhage or brain embolism. So if the patient has reduced level of consciousness, if the patient is looking drowsy, obtunded or unconscious, it is more likely to be a hemorrhagic stroke. If the patient also has neurological signs, localizing signs, then it could be intracerebral hemorrhage. If the patient does not have localizing signs, no focal signs, then it could be subarachnoid hemorrhage. Although again, loss of consciousness is also common in those strokes involving large posterior circulation strokes. So these are the 5 clinical findings. If these are present, think about intracerebral hemorrhage. Remember, this clinical examination is going to take less than 10 minutes, and all these points that we are discussing have to be completed in 10 minutes, because within 15 minutes the patient is going to be wheeled into the CT scan, and ultimately CT is going to decide to rule out hemorrhage, right? So if there is onset during a hypertensive crisis, number 1. Number 2, progression of symptom within minutes. So the patient progresses very fast. Excessive vomiting, early or immediate loss of consciousness, and acute onset of headache. So if one of these is present or all of these are present, it is more likely that the patient has hemorrhage rather than a thrombosis or ischemia. Once you determine that the patient has a stroke, then in short time, please assess where is the stroke. So whether it is in the anterior circulation, means internal carotid artery circulation, or posterior circulation, means vertebro-basilar circulation. So consider these few points. If the patient has motor weakness in anterior circulation stroke, if the patient has weakness on face and the hemiparesis, that will be on the same side, what is called as uncrossed hemiplegia. So big right MCA infarct will have left facial weakness and left hemiplegia or hemiparesis, while in posterior circulation stroke, if the stroke is on the right side, patient will have crossed hemiplegia. Ipsilateral facial weakness will be on the right side, and the hemiplegia or hemiparesis will be on the left side. So if there is crossed hemiplegia, think of posterior circulation stroke. Similarly, vision, if affected, the ipsilateral eye will be affected in anterior stroke, and visual loss will be either on the contralateral side or both sides in the posterior circulation stroke. Speech, the anterior circulation stroke will have aphasia, while the posterior circulation stroke will have dysarthria. Dysarthria means inability to properly articulate speech. So that is different from aphasia, when the speech is absent from the neurological center. Sensory, similarly, if there is deficit, that will be on the contralateral side, on the face and on the limbs. Here it will be ipsilateral face involvement and contralateral limb involvement. Cerebral signs and multiple cranial nerve involvement will be typically very rarely seen in anterior strokes and commonly seen in the posterior stroke. So if the patient has crossed hemiplegia, if the patient has cerebral signs, if the patient has multiple cranial nerve involvement, then think of posterior circulation stroke. Now we will consider few syndromes which are more common. The most common is the middle cerebral artery syndrome. 90% of all the strokes involve the middle cerebral artery. So middle cerebral artery supplies most of the outer surface of the frontal, parietal and temporal lobes, and in the depth it supplies the basal ganglia as well. So patient will have contralateral weakness, sensory loss, again contralateral, homonymous hemianopia. If the left hemisphere is involved, the patient will have aphasia, while if the right hemisphere is involved, the patient will have hemineglect. The second syndrome is the anterior cerebral artery. Since it involves the top area of the brain, it will have contralateral hemiparesis and sensory deficit, but it will be more pronounced in the lower limbs because the representation is upside down. Upper part of the brain represents the lower limbs. The patient may have urinary incontinence. Patient may have apraxia. Apraxia is difficulty in doing certain, suppose like donning a shirt or something like that. Anosmia, loss of smell, and if it is bilateral, the patient will be either mute or the patient will have inertia or apathy. This posterior circulation and basilar artery stroke we have already covered in the how to differentiate between anterior circulation and posterior circulation stroke. So this is most probably a repetition slide. So ipsilateral cranial nerve palsy and contralateral motor or sensory deficit, that is crossed hemiplegia, or there could be bilateral motor and sensory deficit, like something like quadriparesis. There could be disorder of conjugate eye movement. If it is vertical, then the lesion is in the midbrain. If it is horizontal, the lesion is in the pons. There could be cerebral involvement, we have already talked about it, altered consciousness, and dysarthrophonia, the problem in taking out sounds from the larynx, and dysphagia. Horner's syndrome, we will see Horner's syndrome shortly, also seen in carotid artery dissection. Contralateral homonymous hemianopia. As we have seen in posterior circulation stroke, if there is visual deficit, it would be either bilateral or contralateral. Bilateral lesions could cause cortical blindness, which is called as Anton syndrome, and there could be behavioral disturbances. This is the Horner's syndrome. This side you can see ptosis, pupil is small, meiosis, there will loss of ciliospinal reflex, anhidrosis and anophthalmos. So this is because of the involvement of the sympathetic fibers. Acute occlusion of basilar artery, this is a medical emergency. This is rare, luckily, only 1% of all strokes, but can result in death. So it can result in thalamic or brainstem infarction, typically present with sudden onset, severe neurological impairment, depending on the position of the occlusion. If it is proximal occlusion, there could be quadriparesis with preserved consciousness. But if the occlusion is distal, then it will be associated with visual and oculomotor deficit and behavioral disturbance, somnolence and hallucinations. Sudden death or loss of consciousness is possible. So if such a presentation is seen, the patient probably has a quadriparesis, is deeply somnolent or is conscious but unable to communicate, then rapid treatment is essential to minimize the risk of death. The patient is therefore, those patients in which you consider basilar artery occlusion require urgent transfer to a center, comprehensive stroke care center, where they have treatment facilities for endovascular treatment. Now, lacunar stroke presents in a little different way. In the lacunar stroke, as we have seen in the last class, there is the involvement of deep branches, the branches that go into white matter. So, typically the cortical signs are absent. So, lacunar syndromes lack findings such as they don't have aphasia, they don't have agnosia, they don't have neglect, they don't have apraxia, they don't have hemianopsia. Also, typically monoplegia, stupor, coma, loss of consciousness and seizures, they are also absent. Depending on the site of occlusion, they could have pure motor stroke when there is a lesion in the intercapsule or basal pons. They could have pure sensory stroke when the thalamus or corona radiator is involved. They could have sensory motor stroke when their intercapsule, basal pons or thalamus is involved. When they could have ataxic hemiparesis when thalomacapsular infarct is present, or they could have dysarthria, clumsy hand syndrome, where basal pons, internal capsule or corona radiata lesion is present. This the upper part of the slide we have already covered in last lecture, so we will not discuss. So these are the 5 presentation of lacunar stroke: pure motor, pure sensory, sensory motor, ataxic hemiparesis and dysarthria or clumsy hand syndrome. After you have delineated with stroke and you have made a image in the mind, whether it is anterior circulation stroke or posterior circulation stroke, think about the mechanism of stroke. So, do you think it is thrombosis or embolic? We have seen this slide in our last lecture. Thrombosis, if it is present, there could be stuttering progression, there could be atherosclerotic risk factors. And in embolic, the patient could have a structural heart disease like AF or rhythm abnormality, a valvular disease, and they have maximal deficit at onset and can be precipitated by any type of exertion. So these are the findings which suggest that it could be embolic. The onset is sudden and neurological deficit is maximal at onset. The infarct and deficit are large. There is a known cardiac or large artery lesion, for example arch of aorta or heart lesion. The infarct either is or becomes hemorrhagic in CT or MRI. There are multiple cortical or subcortical infarcts in different vascular territories, so that cannot be explained by thrombosis. And lastly, clinical findings sometimes suddenly improve what is called a spectacular shrinking deficit. So if these findings are present, think about embolic stroke. Also, in physical examination, skin should be examined for signs of endocarditis, purpura, ecchymosis, evidence of recent surgery or some invasive procedure. Fundoscopic examination to see for papillary edema or cholesterol emboli. Head should be examined for trauma, and a tongue laceration may suggest a seizure. If there is history of fall, sometimes the patient may have stroke and fall down, or sometimes the fall itself may cause a deficit which could mimic a stroke. So, neck should be immobilized until nexus criteria or Canadian C-spine rule clears the neck. Then examination of extremities to look for evidence of systemic arterial or arterial emboli, dystemic ischemia, see for cellulitis, look for DVT. If the patient has DVT, then check whether the patient is taking any anticoagulation. Lastly, think about dissection of cervical arteries. This is a different type of stroke. This typically occurs in younger patients who have either a recent trauma or infection. Signs of connective tissue abnormalities such as hypertensive joints, Marfan syndrome, Ehlers-Danlos syndrome. These are the patients who have more likely to develop dissection. The characteristic clinical presentation is a focal neurological syndrome in combination with unilateral headache, neck pain, pulsatile tinnitus. Means you hear the tink 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 tinnitus inside, you hear that sound in your ear, and ipsilateral Horner syndrome in the case of internal cavity artery dissection. So, you have a clinical presentation of headache, neck pain, tinnitus, and Horner syndrome and neurological deficit. In unconscious patient, do not forget to see the pupils, because if it is large stroke and patient is likely to cone, means uncal herniation that could be life threatening. So, you should be able to detect it. See for other brainstem reflexes like Dolce reflex. The reflex status, see the position of the patient, whether the patient is decerebrating. Observe the spontaneous activity and reaction to painful stimuli. Lastly, assess how severe is the stroke. We have seen whether it is stroke, number one. We have seen what kind of stroke it is, whether it is anterior posterior circulation stroke. We have seen what is the likely mechanism, and now we have to see what is the severity. So, most of the centers use this National Institute of Health stroke scale. So, there are points for every examination detail. First, you start with level of consciousness. If the patient is alert, you get 0 point. If the patient is in coma, 3 points. I am just going through this NIHS scale is seen, there are various apps and you can easily measure the NIHS score. I am just giving you an idea, so we will browse through it a little faster. You have to ask some orientation questions like what is the age and what is the month. If the patient answers both correctly, you get 0 points. If the patient answers neither, 2 points. Then response to commands, you ask the patient to close eyes and open, and close fists and open. If the patient cannot perform either, then 0 point. Cannot perform either, then 2 point. If perform both correctly, then 0 point. Gaze, if it is normal, 0. If it is gaze palsy, 2. Visual fields, no visual defect, 0. Partial hemianopia, 1. Complete hemianopia, 2. And bilateral hemianopia, 3. Then facial movement, if it is normal, 0. If it is complete unilateral palsy, 3. Then you assess the function of each limb. You start with motor function, left arm, all these, then right arm, all this. So that you start with, if there is no drift, 0, drift less than 5 seconds, 1, falls before 10 seconds, 2, no movement against gravity, 3, and no movement, 4. So you do it individually for left arm and then for right arm. In leg, similar 5 points. If there is no drift, 0, drift before 5 seconds, 1, touches support before 5 seconds. So slight difference than the upper limb, and no movement against gravity and no movement. So you again calculate for left leg and then right leg. Then see for ataxia. If there is no ataxia, 0. If it is ataxia in both limbs, 2. Then sensory loss. If it is, there is no sensory loss, 0. If it is severe sensory loss, 2. Language, normal 2, mild aphasia 1, severe aphasia 2 and mute or global aphasia 3. Then articulation, normal 0, mild dysarthria 1, severe dysarthria 2. Lastly, extension or inattention, if there is normal 0, mild loss of one sensory modality 1 and severe loss of 2 sensory modalities. So when you add up these points, you get a total score. So if the score is 0, there is no stroke naturally. If the score is 1 to 4, there is a minor stroke. So usually you do not thrombolize these minor strokes. 5 to 15, moderate stroke. 16 to 20, moderate to severe, and 21 to 42, this is severe stroke. So this is how you get to the severity of the stroke. So all this data is being collected. As soon as the patient comes, while you are examining, simultaneously the blood samples and imaging should be done. Blood glucose is the first thing to be done. If oxygen saturation is less, you start with oxygen. Send serum electrolyte, CBC, renal function test, complete blood count, platelet count, liver function test. If you think of cardiac ischemia, TROPA, ICP, coagulation parameters like prothrombin time, INR, APTT and ECG. Remember, all tests should not delay the CT scan. So these are the critical time periods that you have to achieve in a stroke patient. Door to physician, the physician should see that patient in less than 10 minutes. Door to stroke team, the stroke team should be activated in less than 15 minutes and the patient should be attended to by the stroke team member in less than 15 minutes. Door to CT initiation, patient should be inside the CT machine in less than 25 minutes. Door to CT interpretation, a neurologist must see the CT scan within 45 minutes. Door to drug time, if the patient is a candidate for thrombolysis, then he should receive thrombolysis within 60 minutes. Administration of fibrinolytic from onset of symptoms 3 hours. So from the onset of symptoms, it was earlier 3 hours, now it has been extended to 4.5 hours. Endovascular therapy up to 6 hours, and door to stroke unit admission. After completion of this acute phase of treatment, the patient should be shifted to the stroke unit in less than 3 hours. So these are the targets that are supposed to be achieved. Thank you. So this was about the clinical features. In the next lecture, clinical features, findings, and the next lecture will talk about the imaging in stroke. If you are liking these lectures, please like, subscribe and share. Bye-bye.